everybody. Welcome to All Things Cancer. I'm Terry PT, Director and founder of a nonprofit supporting patients with education about all options for breast reconstruction after mastectomy called Deep Sea Foundation. Our guest today is Dr. Minas Chrysopoulo from PRMA, which stands for Plastic Reconstructive Microsurgical Associates out of San Antonio, Texas. The topic today is possible risk and complications of breast reconstruction, both implant and autologous based. Dr. C has been named one of America's top surgeons and is routinely featured in the media for his contributions in the field of breast reconstruction. Dr. C, as his patients call him, has dedicated his professional life to advocating for breast cancer patients. He strongly believes that shared decision-making between physicians and patients is crucial in achieving the best results and has built his practice on this philosophy. Dr. C, welcome to the broadcast today.
Thanks for having me.
Absolutely. All right, so I would like for you to start today. I think not assuming that our viewers know anything at this point about the different types of breast reconstruction, can you give us a brief overview of the difference between really the two basic choices in breast reconstruction after mastectomy, and that would be implant-based and autologous-based, or using your own tissue?
Sure. Well, there are pros and cons to each, which we can talk about all day, really. But just in basic terms, implants are it's a man-made implant, just like women get when they have a cosmetic breast augmentation. The process is different, the outcome is different. You can't really compare the two in terms of what the patient goes through, but the actual product, what comes out of the box to use for the reconstruction, is the well-known breast implant, either made of it's a silicone shell and either is filled by saline or silicone. Tissue reconstruction involves the patient's own tissue. That tissue has to come from somewhere. So that involves a scar somewhere else on the body to get the piece of tissue or flap that's then transferred to the chest area to reconstruct the new breast. As I mentioned, there are pros and cons to each, but either way, for most patients, it's a staged approach. It's not a quick approach or a quick process, and most women will end up needing more than one procedure for the best results. The pros and cons depend on, really focus on the length of surgery, hospital stay, length of recovery, and need for future surgeries. Implants are a quicker surgery, shorter hospital stay. It used to be a much quicker recovery than tissue, not so much anymore, and we can touch on things that are changing in terms of the recovery pathways we're using these days. The biggest biggest advantage to implants is that you only have to worry about recovering from surgery in one area of your body as opposed to two. Probably the biggest downside to implants is the high risk of needing further procedures over time because of implant-related problems. Implants are man-made; they're not natural. They can develop issues, and we'll talk about those. But in general, those are the differences between the two.
Yeah, and I'd like to add here that part of my foundation work is advocating for both implant-based and autologous, but I personally chose autologous-based. I chose deep flap, and part of the reason that I chose it was I was a bit of a purist, and I didn't want anything foreign in my body, and I wanted the look and feel of a natural breast. And from my perspective, that's the way my breasts look now. They're warm to the touch. albeit there are numb portions of it, which happens during mastectomy and breast reconstruction. You cut nerves, you cut parts of your body, that's going to happen. But I like the warm, natural feel of my breast. So that's what I chose.
Mm-hmm.
And I'm happy to say that you did an excellent job. You were my surgeon. And so
Thank you
I'm
so
very,
much.
very happy with the results. So Dr. C, let's talk about what it takes for you, either autologous based or implant based, what it takes to have a good outcome. What does that look like to a surgeon, and how do you coordinate all this? It
Mhm.
takes really a team effort.
Yeah, that's a great question. So, women and men, for that matter, can have a very good outcome regardless of the option they choose.
Mhm.
Right. So, um, it's really about matching the best procedure for that person, both in terms of their preferences and also their situation and their other treatment. You know, what kind of stage of disease they have, whether they're going to have radiation. Those are the two main issues from a medical perspective.
Mhm.
And of course, as with any surgery, how healthy they are and any other medical problems they may have, that can also influence choices. All that being said, the best advice I can give to patients when they're looking or considering breast reconstruction or any surgery for that matter that involves more than one surgeon or more than one specialty, um, it's all about finding the right team of individuals. So you want a multidisciplinary approach. The single biggest impact, I think, on the final reconstructive result for women that are having reconstruction, especially at the same time as the mastectomy, is actually the quality of the mastectomy.
Yeah.
So that can make or break implant reconstruction in particular. Um, One of the uh, benefits of tissue that we perform a lot of in at PRMA, we're very pro tissue. One of the benefits is that it's not, if you have a poor mastectomy flap or if things don't go the breast surgeon's way in terms of the mastectomy flap, um, or if for some reason the blood flow that's left behind isn't the best, the fact that you're bringing healthy tissue up to the area is more forgiving.
Mhm.
In an implant reconstruction setting, if you have a very poor mastectomy flap, then that can break the whole deal,
Mm.
right? So you can get a very, very good reconstruction with implants. There's absolutely no question. And the right person with the right mastectomy flaps and the right team, it can be the best choice for people.
Right.
It's all about minimizing risk. And the biggest thing a patient can do to minimize risk is to pick a team that does this every day and composed of individuals who work together very frequently, because you know it's medicine, it's surgery, it's complications happen to all of us.
Absolutely.
So I think anyone who says that they haven't had a complication or that's never happened to me, it's either isn't operating enough or is delusional, right? So if you've been doing it long enough, you've had complications. So it's all about minimizing that risk, and the
Right.
team is crucial.
Yeah, and I have to mention in my own circumstance, um, you know, and it was my circumstance. It's just different for everybody. I had my mastectomy in one town, reconstruction with you in a whole different state. So I had to travel. So I guess the message that I would like to give to patients is, and I didn't do this at the time, ask your breast surgeon, ask your team, you know, there's so much to think about when you're going through breast cancer, but I do hope patients remember to ask this. Um, what is it that you can do as a breast surgeon to coordinate with a plastic or microsurgeon that I will be going to out of state. Now, I was very fortunate because my breast surgeon, number one, knew that I was going to have deep flap. I did communicate that to her. However, I I I hadn't found you yet. I hadn't done that research just because of my personal circumstances, my treatment, a number of things. I said, I want the breasts off. I want the vessel holding the cancer off. Her schedule, my training, or my train of thought, I wanted the breasts off. So I had the surgery, but she was able, because she knew I wanted to do deep, to do a skin sparing, nipple sparing mastectomy. And it wasn't pretty for 7 months until I came to you, and you made it pretty. But in those 7 months, my skin fold was there. And I guess that's an advantage now, yes? Because
Absolutely.
that skin fold kind of looked like, I'd say, a Chinese Shar-Pei, and I didn't like the looks of it. But now I look back and I think that was the envelope bits of it that you had to work with.
Yeah, it's a means to an end, and the reconstructive surgeon will want as much skin typically, saved as possible, because that really does help us out in terms of creating the nicest shaped breast that we can and maintaining as much of a natural shape as possible. The more skin, the better, generally speaking. It certainly takes finding a breast surgeon who's, an advocate for reconstruction, and having that conversation, and the patients really has to be okay with all the extra stuff just being there, for later. There's a tendency, a lot of breast surgeons like to leave things neat and tidy. Yes. And they don't want to leave the extra skin because it won't look as neat, and sometimes it takes a bit to, convince them, look, it's okay, it's on me, I want the kind of excess skin thing because I'm going to have reconstruction, it's okay. So patients should push for that if they know they're having reconstruction. Of course, if they don't know, then it's okay too, right? So it helps us having the extra skin, but we don't need it. It's not make or break. It's nicer if you have it. So certainly if someone initially starts off thinking that they don't want reconstruction, or they don't want to think about it right now, or it's just too much, or maybe later, or or I'm just not interested,
And then they might change their mind later.
Yeah, it's the options. The final choice doesn't actually matter really that much. It's, for me, it's the individual having the choices, all of them.
Yes.
And then working out what's best for the individual. There's no best option here. It's just the one that's best for you. But,
right. So speaking of which, we do know statistically that more women choose implant-based reconstruction. So I want to go back to some of the possible risks that can happen during implant-based. Can you explain to us physiologically about capsular contracture? Because I know that is a possible risk with implant-based.
Yeah, so capsular contracture is the biggest risk that we have long-term with implant reconstruction. That's probably the number one reason for needing a revision surgery to adjust things. Whenever you put anything foreign in the body, you see it when you get, you can get a splinter in your finger. If you don't remove the splinter, sometimes it just gets, scarred around the splinter, and the splinter stays in your finger. The body walls it off. It reacts, forms scar, and walls it off. There are plenty of war veterans walking around with bullets in them that aren't causing any harm. The body just walls it off. So you can think about a breast implant as the same thing, more or less. The body creates a capsule of scar around the implant. It recognizes it as a foreign object, and it walls it off. Now, in some women, that scar capsule remains very soft, it's very thin, they don't even know it's there. Other women develop a very aggressive reaction in the capsule, and the scar gets thicker and thicker and thicker over time, and then it squeezes down on the implant, and it can deform the implant. It can change the shape and look of the breast. It can make the breast tight and elevated and what we call contracted, and it can even be painful for some women. So even if women tolerate the change in appearance over time, because it's not that bad, sometimes it's the discomfort that's caused that's a trigger for them to want something done about it. And so we actually see a lot of women that have had implant-related issues, and the number one is capsular contracture, especially after radiation, because implants are performed in conjunction with radiation all the time, but there's no question, there's a lot of evidence out there showing that implants do not do well when radiation is in the mix. Either putting an implant in someone who's been radiated, or doing a reconstruction with an implant and then radiating it. You can do it. Plenty of plastic surgeons do it. There are lots of women in that situation, but there's no question that the radiation increases the risk of implant-related problems, especially capsular contracture. We very much, there are two camps of reconstructive surgeons, I think. One camp is, you can get it to work. It works just fine a lot of the time. Others are completely against implants and radiated, in the setting of radiation. Our practice, we're in the latter camp. We like to avoid implants when radiation is in the mix. So we'll avoid implants at all costs in that situation. But again, it's part of the shared decision-making approach. If patients are okay with it, some patients don't have a choice. Here we are talking about, tissue versus implants. Some ladies can't have tissue. They have hardly any tissue anywhere. When your BMI is 17 and you're doing a bilateral mastectomy, because you're a BRCA patient or something, you don't have great options if you really want to be a C cup, right? So you're looking at either implants or a combination of tissue and implants. All these comments are very general comments with, in the situation where everything else is equal, right? So some women, unfortunately, don't have all the choices or all the options.
Oh yeah, it's so individual, because we're each individual. When we come to the table, excuse the tongue in cheek, but we literally come to the table with such a variance in, body chemistry and body physiologic, just the way we're shaped and what we have to offer, and just the personal choice too.
Yeah, and the way each person reacts to treatments, right? So you can have two patients, two different people, same disease, same surgery, both getting radiation. One does absolutely fine, and the other one has issues, because you can't control for the way the body reacts to certain things. And then, specifically in terms of radiation, radiation's come a long way, but one of the biggest things we can't control is how the individual is going to react to it, so.
Yeah, and it was certainly a hot topic when I went to the San Antonio Breast Cancer Symposium in December. There was, a general session on the dilatory effects of radiation with breast reconstruction. So I'm glad you brought that up.
Well, and it also, and it doesn't just affect implants either. So I don't want people to think that, I'm going to have radiation, so I'll have tissue and I'll be fine. Tissue is definitely, in my opinion, and there's plenty of evidence to back this up in the literature, tissue is definitely the much better and safer option when radiation is in the mix. And by safer, I mean less chance of complications. But don't for 1 minute think that just because you're having tissue, everything will be fine, for sure.
Better blood flow, I would think.
Much better blood flow. Yeah, if you've had radiation in the past, bringing tissue up there, that really does help. having healthy tissue in the area in some ways also can help reverse some of the changes caused by the radiation, or at least kind of stop them. But we do see things soften up when you reintroduce healthy tissue, soft, warm, with a good blood supply, like a tissue flap. But the timing of the radiation is also something to consider, because if the patient is having a mastectomy and radiation is planned after the mastectomy, and this is a patient who wants to have reconstruction, then the question becomes, when's the best timing to have the reconstruction? Should I have it before the radiation or after? Based on complication risk, the absolute safest time to have reconstruction is after the radiation is done. So the patient would have a mastectomy, have their chemotherapy, have their radiation, then come back for a tissue reconstruction.
Yeah. Well, and I have to say, in my instance, for my second occurrence, I didn't have to have radiation, but I did have radiation 12 years previous to my reconstruction. And the benefits of replacing that were absolutely a night and day for me. I used to not be able to lay on my left side for 12 years. And after my reconstruction, when that tissue was replaced, that scarring and that radiated tissue was replaced with a flap, I lay on my left side all the time now comfortably. So it really, in proof positive from my standpoint, it worked.
Yeah, there are some places, so again, this puts the onus on the patient to do the research, but there are some places that do a very, very good job of doing the radiation after the reconstruction.
Okay.
Right, specifically the tissue reconstruction. And again, this speaks volumes in terms of the team approach and communication. Not all radiation is delivered in the same way. Experienced teams, radiation oncologists who have experience with breast reconstruction will adjust the way the radiation is delivered to decrease the risk of complications in terms of ruining the reconstruction, but they do it in a way that doesn't compromise the cancer care, because that's obviously the most important thing. It's life before breast.
Right.
Other places don't have the same experience or the same philosophy, and they treat everyone in exactly the same way, and that will increase the risk of complications and issues and problems with the reconstruction if the reconstruction is performed before the radiation, which is why, generally speaking, the absolute safest way is to delay until after the radiation is done. But there are, in some parts of the country, or if patients are willing to travel, you can still have immediate tissue reconstruction, i.e. at the same time as the mastectomy, even if radiation is planned for later. So again, it's all homework, communication, and asking.
Team communication. Absolutely. That's a very, very good point. You know, I want to ask you about a couple of things that are sort of similar, but not really. It's about fluid collection of two different sorts. I've heard women talk about hematoma and seroma. Can you tell us the difference between the two and how that happens? Really, I think it could happen in both implant and autologous. Is that correct?
Yeah, absolutely. So hematoma, so bleeding, and if you get a collection of blood, that's called a hematoma. A seroma is a collection of other fluid. Whenever the body is traumatized, whether it's on the outside or on the inside of your body at the time of surgery, whether it's a superficial skin burn or a major internal surgery, the body produces fluid as part of the healing process. And if that fluid collects, you get a fluid collection called a seroma. So seroma is a fluid collection. That's why we use drains in many types of surgery. The drain is there to allow the fluid to be removed from the body so it doesn't collect. Now we're moving more and more towards drainless surgery using other techniques. But in general, that's why we use drains, is to prevent the seroma. A seroma or a hematoma or infection, for that matter, that can happen after any surgery. Doesn't matter. And in terms of breast reconstruction, doesn't matter whether you're having an implant reconstruction, whether that's a traditional staged implant reconstruction with tissue expanders and then implants, or whether it's a direct to implant, or whether you're having a flap from another part of your body. Those complications can happen with any of those procedures. What I will say, though, is that seromas are more common with implant-based reconstruction, because most implant-based reconstructions, whether it's the traditional two-stage or the direct-to-implant, most of those implant techniques use dermal matrix or acellular dermal matrix. Your viewers are probably going to be familiar with things like Alloderm or Stratus or Dermacell, or there are lots of different brands. But that dermal matrix is used in the vast majority of implant-based reconstructions, and it does increase your risk of seroma a little bit.
Is it because it's a foreign body, or an added foreign body, or?
That's a great question. There are lots of different theories behind it, but don't know for sure.
Okay. Yeah. Well, and as far as drain management too, the thought just crossed my mind. That is very individual, because I hear women, mine were out in 2 weeks, but I hear women say that sometimes their drains are in for 6 weeks. Again, it's an individual body response, I would think, correct?
Yeah, for the most part, but also there are techniques that you can use to decrease the risk of fluid collections, so that the drains can come out sooner, or so that you can avoid using a drain at all. So we're moving towards drainless abdominal surgery in our practice, where we use a lot more internal suturing techniques, so that there isn't enough space or there's less space for fluid to collect. So that even if you do still use drains, instead of using 2 abdominal drains, you're only using 1, or none at all.
Interesting.
And then even if you do use a drain, it's coming out a lot sooner. So that's the whole recovery pathway really has changed a lot fairly recently. We use an ARAS protocol, enhanced recovery after surgery. That's what ARAS stands for.
Yeah. How have things changed? It's been 2 years since mine.
Yeah, things have changed a lot.
Yeah, let's talk about that, because I mean that's
So
the progress of science and everything, right? Talk to us about some of the changes, after in the hospital and recovery. Speak to us about that. I'm curious.
So there's some pioneers of this. Really did a lot of great work looking at what could be done to help patients recover quicker. So we didn't pioneer this; we're just using it now. There's a lot of good work out of the Mayo a few years ago, and it's gained more momentum. It's got more places are looking at it. We've got our hospital stay now down considerably. Years and years ago, a bilateral deep flap procedure would stay for 4 or 5 days. In other institutions, they would stay in, and I think some still do. They stay in the ICU for a night, maybe 2, and then go to the ward or to the floor, and they can be there for 5-7 days. I think, now the places that are doing a lot of these types of procedures are really, really speeding up the process, the recovery process. We start with, for us, the protocol starts the night before surgery. Patients are now taking a clear carbohydrate-loaded drink that helps prevent postoperative nausea. They take another drink. It's a clear liquid. They have another one in the morning of surgery. So it's not NPO after midnight anymore. They're allowed to have this clear carb-loaded drink. We also give them pain medication the morning of surgery before they even go into surgery. We're using less IV fluids during surgery. We're using local anesthetic a lot more during the time of surgery, a long-acting version. And we're injecting it around the specific nerves, especially in the belly, so that postoperatively with our deep flap procedures, the abdomen isn't really a big source of discomfort anymore. It used to be the source, a little bit in the chest in the middle, but mainly the abdomen, but that's all changed now. Because of this carb-loaded drink, there's less nausea afterwards. So patients are able to eat quicker. So the diet is advanced quicker. They're getting out of bed sooner. They're walking the same day of the surgery. They get to the floor after surgery, then that afternoon or evening, they're walking. It used to be that they would stay in bed for a day or something, depending on where you were, which institution. The Foley catheter is coming out very, very, very soon now. Because of all the extra pain maneuvers or techniques we're using to cut post-op pain, there's a lot less narcotic use. So our patients, for example, basically they're on Celebrex and extra strength Tylenol, and they use narcotics for breakthrough pain. They leave the hospital at 3 days or at 3 nights. They're out, and the recovery is really a lot quicker. It used to be that we would tell folks having deep flap surgery that, 4 to 6 weeks, 6 weeks off work, and, kind of slow and listen to your body, and implant reconstruction is a lot quicker. It's 3 to 4 weeks and all that stuff. I mean, in terms of work, we still tell folks, tell your employer 6 weeks because that's worst case, and it's better to go back early and look like a rock star than, right? So in terms of work, I still tell my patients 6 weeks, but to be honest, I mean, people are walking in at 4 weeks and you have to remind yourself, did we? Yeah, we did operate, they look, is that a patient? Is that a drug rep? It's completely changed. So that's another thing for patients to discuss with their team is, what kind of protocols are used before, during, and after surgery to help with the recovery. How long will I have my Foley? When will I be up walking? What pain meds will I be on? Will I be on narcotics? That kind of stuff. It's a lot of finite detail, really, when there's so much else for patients to think about, especially in the midst, for patients who are dealing with a recent diagnosis. There's so much, now we're adding all this. Really, in the huge scheme of things, it's minutia, but it's what helps you get through it. It's a lot easier for ladies that are doing the reconstruction after the fact. They've got a lot more time to focus on the details because the emotion and the stress and the anxiety of the actual diagnosis is well under control because that's all done. The treatment's done. For some women, it's years later. So it's a different focus,
Those are some amazing changes. And I have to say, I'm 2 years out and I don't want do-overs. But the Foley catheter, that would be, and this carb drink that you give them, the pain in the morning. My pain was very well managed in the hospital, but I did stay, I was out of town and I did stay 5 days. I didn't get out of bed till the next day. Those are all really positive, great things that you bring up. And as we know, all protocol is different. So why not ask the questions that you put out there? We know that it's not going to happen everywhere, but why not put out the questions? So thanks for all that great information.
No worries. And it's just, it's the concept in terms of the protocol. It's not necessarily going to be the identical protocol in every institution. And, the different logistics that each institution has to deal with can also impact the protocol. But if they have their own version of this ARAS pathway, that's what speeds things up.
Can you give us the words that are associated with that acronym?
ARAS is Enhanced Recovery After Surgery.
Okay, ERAS, ERAS.
And it's just it's a philosophy, really. It's a methodology, rather than a specific, everyone, and so it can vary between hospitals, the exact medications they use and the exact timing of things, but it's a principle. And it's being applied now to lots of different specialties. So, I mean, they have it for urology, they have it for microsurgery, they have it for, you can find specific pathways for specific procedures.
That's great information. ERAS, my new favorite word today.
Yeah, should blog about it.
I think I will.
Yeah, there you go.
You've given me lots of topics. I'll be writing a blog, and wrapping up this conversation that we had today, which is just really hit on a lot of good possible risks and side effects. I want to talk about one more. I know your time is precious. We may have to do a second run on this. I think that sounds like a good idea. We've got so much more to talk about. But the other thing I wanted to ask you about is abdominal wall hernia. And of course, that would be specific to autologous, since you're working in the tummy area.
So autologous, just to backtrack a little bit, autologous reconstruction, like you said, involves a tissue from somewhere else on the patient's body, right? But there are lots of different tissue options. So we can take tissue from the tummy. There are various different forms of that. There's the traditional tram flap. There are different types of tram flap, but each of those remove either all of the tummy muscle, the abdominis muscle, or part of it. And then you've got the deep flap, which preserves the muscle, and then you've got the SIA flap that is the same skin and fat as all those other tummy procedures, but doesn't even violate the muscle because the blood vessels travel on top of the fascia, which is the skin, the tissue layer on top of the muscle. So the recovery with the SIA flap is the least of all of those abdominal-based procedures. Unfortunately, not everyone's a candidate for the SIA flap, but anyway, all those are variations on the tummy reconstruction. The deep flap is very much considered the gold standard now in reconstruction, in autologous reconstruction, or reconstruction in general. Other flap options involve from the back. The most traditional way to move the back tissue is the latissimus flap. You can also use tissue from the buttock area, the upper or lower buttock, and also from the thigh, the upper posterior thigh, so underneath the buttock crease, that's a pap flap. We can use tissue from the upper inner thigh, that's a tug flap or a vug flap, depending on where the scar is oriented. And then you've got various other thigh procedures that use the outside of the thigh. So tissue can be taken from a lot of different places. Unfortunately, few surgeons perform the more complex versions that involve microsurgery. So tram flap, a traditional tram flap, doesn't involve microsurgery because the tummy tissue is tunneled underneath the upper abdominal skin, and it remains attached to the muscle. That's curled under, and the blood supply comes through the muscle, so you don't have to reconnect any blood vessels. And also the latissimus flap, which uses the traditional latissimus flap, uses the skin and the fat and the muscle underneath the shoulder blade on the back. That's tunneled through the armpit. There are other ways to get that tissue over by sparing the muscle, but that's more complex. But some plastic surgeons, so all plastic surgeons offer implant reconstruction, pretty much all, the ones that are doing reconstruction. So that's why it's the most common procedure. It's technically the most straightforward. It's widely available. You don't need specialized training. The other microsurgical techniques involve specialized training, which is why not everyone performs them or offers them. So patients have to do their homework, and a lot of them are going to have to travel, unfortunately.
Mm-hmm.
Specifically in terms of the tummy procedures, the complications we worry about are bulging, which is like a pooch,
Mm-hmm.
and even an abdominal hernia. A bulge can happen when the tone in the muscle, so either the muscle is removed, so any procedure that removes muscle increases your risk of a bulge or a hernia.
Good to know.
Even if you preserve the muscle, like the deep flap does, you can't cut all the nerves that feed it and power it, because then the muscle becomes, essentially it's a paralyzed muscle.
Makes sense.
Paralyzed muscles waste away, they have no tone, they have no power, they don't work. And so then you can get a bulge. You can also get a bulge if you get a partial separation of the repair on the inside. So those are the most common reasons to get a bulge. Again, in experienced hands, the risk of abdominal complications with the advanced procedures like the deep flap, the risk is 1% for a hernia, 3% for a bulge. With an SIA flap that doesn't even violate any of the deeper tissues, you don't have any risk of those two things happening.
Interesting.
Yeah. An abdominal complication, a bulge or a hernia, can be a very, very, very bad event for people.
Yeah.
It can create many chronic problems. It can require significant reconstructive surgery in some cases. Thankfully, that's rare. But so really, the best way to go about things is to prevent it from happening.
Yeah.
And so the way to prevent that is to preserve rather than try and patch, right? So preserve the muscle, preserve the nerves that feed the muscle. So the deep flap or the SIA flap are very much the way to go in terms of minimizing risk for abdominal wall complications.
I have a question, not to interrupt, but I'm hearing everything is dependent upon how a surgeon performs it, how they do this, and what procedure is performed. But there's got to be patient accountability. Is there anything that patients can do post surgery to minimize the chance of hernia or bulging, or is it simply a matter of how it's performed on the table?
Just follow doctor's orders, just follow instructions, don't do too much too soon. Some of the issues, it's been interesting. Some patients that develop problems are ones that feel, especially with, the deep flap, you can have a patient that feels like they can do more than they should be doing because the recovery is going pretty well. That doesn't happen very often, but just follow doctor's orders. If the muscle is removed, there's nothing a patient can do, right? So if you have a bilateral pedicle tram flap and you have none of your rectus muscle left behind and all you have is mesh, there's nothing you can do.
Yeah.
The muscle is gone. If you have bilateral deep flaps and the surgeon cuts all your motor nerves, even though they save all the muscle, your muscle will lose tone. There's nothing you can do after all your motor nerves have been cut, right? So now sometimes nerves are cut, right? So but the thing is that there are multiple nerves. There's more than one typically, and they should be, so as many of them as possible need to be preserved. For example, we preserve all the nerves that we see. And then in the rare event that we absolutely have to cut a nerve, we repair it. So then you've got all the others that have been preserved, and then you have one that was cut and it's been fixed. And so long term, the vast majority of patients can do whatever they want in terms of activity. But if
Yeah.
you go ahead and you cut all the nerves, doesn't matter what the patient's going to do.
Right.
So uh,
That was a good explanation. That helps me understand it a lot better. I have to tell you, Dr. C, this is a broad topic, all of the
it's
possible
massive.
risk, yeah, risk and complications of breast reconstruction. Can we count you in for a part 2 sometime?
We can, yeah,
I,
absolutely.
I, I,
We didn't touch on that latest Times article about numbness, but we can.
I want to talk about that. I want to
You
talk
want to?
about that. That could be
We can talk about that. That's
session in and of itself. Necrosis, more about radiation and wound healing. We didn't even talk on that. So let's see if we can get you on another time. The way you explain things, and your wealth of experience and information and your high success rate with your surgeries, we just appreciate the way you present this to patients. It just brings back a flood of memories. When I sat in your office and I learned about shared decision making and the importance of it. So I think what you've done today is presented the viewers with some thought and some action items to be able to talk to their plastic surgeons about possible risk and complications, and things that we can do to maybe minimize them, or decisions that patients might make differently to avoid some of them. So that's kind of the wrap up on my part. And I really do appreciate your time, and we so
You're welcome.
appreciate,
Enjoy it.
yeah, so
But yeah,
appreciate you.
we can definitely do a part 2. A ton of stuff we didn't talk about, but yeah, we can talk all day.
All right, I'm going to
Yeah.
nail you down on that
All
one.
right, part 2 it is.
Hey, great seeing you. Thanks
Likewise.
again for your time, and we'll end it here and look forward to that part 2.
Sounds good. Take care, Terry.
Thanks so much.
Bye.
Bye-bye.